In this episode, I talked to Dr. Tony Cunningham, a world-renowned researcher of HIV, herpes, and vaccine development. He's also the co-director for the Center of Virus Research at the Westmead Institute for Medical Research in Sydney, Australia. We have a phenomenal conversation here. We talk a ton about vaccine development. Tony was involved in the development, improvement, and distribution of the COVID vaccine, and he knows a ton about the topic. He also knows a ton about vaccine hesitancy. So it was awesome to learn from him about differences in vaccine hesitancy between the US and Australia, and really getting to the root cause of this vaccine hesitancy. We talk about a bunch of conspiracy theories and vaccines that didn't work so well, like the Johnson&Johnson vaccine and AstraZeneca. And we also touch on his research with herpes and HIV, which is really, really interesting. I hope you enjoyed today's episode. You are now listening to the Gustavo Franco podcast, where we challenge the norms and uncover the truths of our healthcare system. I'm your host, Gustavo Franco. Hey, Tony, I'm super excited for our conversation today. We're going to hit on a bunch of topics that are super interesting. I don't really know much about them, so I think this is going to be super insightful. To start off, let's talk about herpes. I know you've done a ton of research here. Let's start at the basics. What is the HSV virus?
So herpes simplex virus is a virus that we've been afflicted with for thousands of years. It's evolved into two types. One that predominantly affects the mouth and eyes, which is called herpes simplex type 1, and one which predominantly affects the genital region, which is called herpes simplex type 2. They're a little mixed because herpes simplex type 1, particularly after oral sex, can infect the genitals, although it doesn't tend to recur. And this is one of the hallmarks of all herpes viruses, that they're able to hide in various cells in the body and then re-emerge at various times to recur. And one of the real problems with both oral herpes and genital herpes is that they recur regularly. The virus itself is a fragile little thing which is susceptible to soap and water, and so in essence, if you wash yourself properly, disinfect surfaces, it's not going to create problems. People used to be worried about catching it from lipstick, that's the type 1, but really you can't. It decays very, very quickly. So when the virus is acquired, either through the mouth in young kids, often under the age of 2, usually asymptomatically, the virus, and the same is true with genital acquisition, which mainly occurs in late adolescence and early adulthood, the virus infects the skin of the mucosa or the mouth and then penetrates through into little twigs of nerves in the skin and travels up these nerves to a cluster of cells close to the spinal cord called ganglia, and it sits there for life and intermittently what we call reactivates and comes down those same nerves and comes out in the same, pretty much the same site each time. Of course, it causes a lot of distress to people, particularly on the genitals, but of course it can also on the face, can get into the eye and cause recurrent eye infection, which can lead to blindness. So it's not benign. And you do get rare complications such as encephalitis in type 1 with the type 2 herpes in the genital region. It's associated with more ready acquisition of HIV. So 30% of HIV worldwide is thought to be acquired through a herpes lesion. So this is not a benign disease. And of course, it used to be called the scarlet letter, once made the front of Time magazine with a big scarlet letter on it, But of course it was superseded by HIV and then by the big one, by COVID. So herpes is not quite as impactful as it used to be. There is no vaccine for it. I've been working on the vaccine in the early 2000s, and there are some more candidates coming out now. You can suppress the virus continuously with antivirals, but that can be a real nuisance, and it doesn't completely stop the virus from being shed without symptoms. And if it can be shed without symptoms, one of the things that worries people most of all is that they can actually infect their partners, and that is the major issue. So it does have psychological baggage associated with it.
And then going back to the idea of type 1 and the type 2 virus, type 1 being the oral version and then type 2 being the genital version, you mentioned that one can progress into the other. Do you mean that in the same person, or if you have oral sex with someone, the type 1 can go into type 2 virus for the genital of the other?
No, what I meant is the type 2 virus is the only one that really takes in the nerves of the genital region and recurs. But the oral sex can lead from a person having shed type 1 virus in their mouth, and they can infect the genital region of the other person with type 1, and it will give you a first episode, but you don't get recurrent episodes. Thanks for clarifying.
Got it, yeah. And then on type 2, is that lifelong right now?
Yes, but it tends to tail off with time, the frequency of these. So you get the most frequent recurrences in the first year, and then as your immunity develops, you don't get them so frequently clinically, probably because the virus is mostly then shed asymptomatically. And the virus can be shed from the genital region very frequently indeed.
Cool. And then I remember in my conversation with Sharon, we talked about HIV and how that integrates into the DNA. Does the herpes virus also integrate itself into DNA?
No, it doesn't. It doesn't have that same enzyme, the reverse transcriptase, which converts RNA to DNA and then pops itself into the genes. The herpes virus sits in the nucleus of the cell, like all herpes viruses, but they exist as their separate little viral chromosome, and they actually use the cell's enzymes to multiply. That's why they get into the nucleus, because they can then be very efficiently spread as a very small particle. They don't need to carry with them all the enzymes needed to multiply, which are found within the nucleus of a human cell.
And is that usually true for both type 1 and type 2?
True.
All right, cool. So let's say you get the type 1 herpes in your mouth. What does that look like? Is it like a week after you get the virus, you're going to get stuff popping up in your mouth?
Yes, 7 to 10 days afterwards, you'll get, if you get disease, and only about 2% of people get disease when they first acquire it, which is very annoying. And I should have said that in Australia, 80% of people are infected with type 1. We did the surveys, and 12% with type 2, commoner in the city than in the country. And type 1 is commoner here than in the USA, where it sinks to about 50 to 60%. And you get it mainly mother to infant, but there's another spike in adolescence, which is, again, as I mentioned, got to do with kissing and all the other stuff that occurs in adolescence. So it actually causes characteristic ulcers in the first episode in the mouth, which are painful, often associated with fever. When it recurs, it causes blisters, and those blisters are characteristic asymmetric. They're not in the midline, they're away from the midline, and they actually form what's called the vermilion border of the mouth, between the pink area of the lip and the skin. They characteristically come out there, and they come out as blisters, and then they ulcerate, and then they crust and go, usually within a week with the recurrent herpes, but with genital herpes, for instance, first episode, which occurs in about a third of people who get infected, The genital herpes lasts longer. It lasts about 2 to 3 weeks.
So are there some people that get it and don't even really notice because they don't get any of those episodes?
Correct. 98% of people who get HSV1 don't know they've had it. And my mother got her first cold sore at the age of 67, and I've never had them. I'm free of all herpes. How about that for a herpes virologist? So my scientists use my blood when they want something that's herpes antibody free. So yes, so 98% of people will get HSV1, that's type 1, asymptomatically, and about 2/3 will get HSV2 asymptomatically.
Oh, that's interesting. But then even if they do get it asymptomatically, type 2, they'll keep that for the rest of their lives.
That's right. And they can recur symptomatically. As I mentioned in my mother, with HSV1, it might be late, or it can occur almost immediately. You get asymptomatic acquisition. It may occur clinically as a recurrence in the first year.
Mm-hmm.
Confusing virus to diagnose.
Yeah.
And how do you diagnose it? Well, the doctor should take a swab of an ulcer, or alternatively unroof the little blister and take some fluid and actually check it by a molecular test called a PCR. And in essence, if you're worried by it, you can either be treated per episode with antiviral agents, or you can be treated by suppression, which means that you take the antiviral agents continuously. They're non-toxic. You can take them up for 5 years.
So how worried overall are we about herpes as like a public health issue?
Well, it's an important public health issue because of the not only itself, but also the acquisition of HIV. So there are 2 types of risk factors for acquisition of HIV, which are co-infections. One is herpes, 30% of cases worldwide, and the other is particularly in women in Africa who have inflamed vaginas due to abnormalities of their, what we call microbiome, their flora, their bacterial flora. We're all colonized by bacteria, but they have abnormal colonization, and they get particularly a bacterium called Prevotella, which can predispose to HIV. So if you can't get an HIV vaccine, if we can get a herpes vaccine, you can reduce the acquisition of HIV substantially.
Got it. So given that you have herpes, either type 1 or type 2, you're more likely to get HIV if you have an encounter with HIV?
That's correct. But it's more common with HSV2, with type 2, because it recurs and type 1 does not.
And is that true only when the virus is active, or even when it's inactive, you still are more predisposed?
You can shed between clinical lesions when you don't know you have it, and you can still acquire the virus. Now, people have shown that you get greater acquisition of HIV in the first 3 months after getting herpes because as I mentioned before, it's more frequently shed in that first 3 months.
Got it. So then going back to the HIV acquisition, how much of HIV nowadays is actually acquired by a patient that had herpes?
I said 30% globally.
All HIV cases?
Yes.
Oh, okay. Wait, that's interesting. That's a lot of it.
A lot of HIV, isn't it? Yeah.
Yeah.
So it's a 3 to 5-fold increase in risk if you have a herpes lesion.
So then,
should I say, infected by herpes simplex type 2.
Okay, now that makes a lot of sense now. So then if you're able to get rid of herpes, basically 30% of case, you get a 30% case reduction in HIV.
Yeah.
Okay.
You can't get rid of it with antivirals. People have tried in many trials using acyclovir, and the reason for it is acyclovir probably doesn't last long enough to completely suppress throughout 24 hours the occurrence of herpes. So we can't do that at present, and it's one of the reasons that I always advance in my grants for herpes vaccines, not only itself, but also to try and prevent HIV.
Mm-hmm. And so I know you also did some work with the SHINGRIX vaccine.
Yeah.
What is the SHINGRIX vaccine?
So SHINGRIX is a vaccine for shingles, and when we started working on the herpes simplex vaccine in 1992, I did a lot of work initially at Stanford University and then back here at Westmead on what were the types of immune cells which are responsible for combating herpes lesions. And I found that these cells were the ones that are likely to be infected by HIV. So it's not just an ulcer, it's the fact that the cells in the base of a herpes ulcer are the ones that suck up HIV, so to speak. So when we started looking at herpes simplex vaccines with GSK in 1992 and the early 2000s, they wanted to use an immunostimulant which stimulated the very cells I found in herpes lesions, so-called CD4 T cells, and the adjuvant was called MPL. It comes from bacterial cell wall and is modified. So we then went on to look at the possibility of controlling shingles, not by using a live vaccine, which is defanged by passaging it through cell cultures multiple times, which is what the normal chickenpox vaccine is these days. This was a vaccine that had a single protein and an immunostimulant in it, and a more powerful immunostimulant than the one we used in the herpes simplex vaccine. So SHINGRIX consists of a single chickenpox virus protein called glycoprotein E. It's found on the surface of the virus, and we put it together with an immunostimulant. That immunostimulant is the one that was used in the herpes simplex vaccine, which was only partially successful only in women, surprisingly. And so we used an immunostimulant that had two components. One was MPL, found in bacterial cell walls and modified, and the other one is called QS21, and that comes from the bark of a South American tree called Quillagia saponaria. So QS21 is the reason for it. When you put that all together, what we found, to our surprise, is that you got a great immune response to the vaccine. We now know that shingles that occurs in 1 in 3 people and causes a rash like herpes, but it's a larger rash and often goes from the spine at the front to the sternum, spine at the back, the sternum in the front. That rash and pain is very common and very nasty. The pain in particular is nasty, and it can last 12 to 16% of people for up to a year. So not a pleasant condition. And why do we get shingles? We get shingles mainly in people over the age of 50, and we get shingles because of declining immunity with age. People like me have got declining immunity. And it's particularly the white cells, the T cells, that actually control the chickenpox virus from getting out of this cluster of nerve cells. Just like herpes simplex, same sort of cluster of nerve cells next to the spine, but it usually only emerges once or twice in a lifetime. So the idea was to re-stimulate these white cells, these T cells, with a shingles vaccine. As I mentioned, the first one was like a concentrated chickenpox vaccine. The second one was the one I described, single protein with an immunostimulant, and we found that produced remarkable efficacy, over 90%, even in people over the age of 80, and we've now found that the efficacy persists over 80% for 10 years. So it's a terrific vaccine, particularly in the aging.
Yeah, no, that's cool. So when you have herpes, are you more predisposed to getting shingles, and should you take the SHINGRIX vaccine? Or?
No, they're completely different viruses. One is the herpes simplex virus, the one that causes the cold sores and the genital herpes, and the other one causes chickenpox, which of course is a disease of kids usually, and the virus again goes to sleep in this cluster of cells close to the spinal cord. So they're related, and they may even coexist in that cluster of cells in the spinal cord, but they're quite distinct. There is a little bit of cross-immunity between them, but you can't rely on that. You need a shingles vaccine for shingles, and you need a herpes simplex vaccine for herpes.
And so should the SHINGRIX vaccine be taken as a preventative measure, or?
Indeed.
Okay.
It's not a treatment, it's a prevention. And if, as I said, shingles goes up over the age of 50, keeps going up over 60, 70, 80, and you start to get the prolonged pain of shingles really over the age of 60 and particularly over 70. So in Australia, we now recommend the shingles vaccine free for people over the age of 65.
Cool. Oh, that's really interesting. Okay, so now let's go a little bit into the COVID vaccine. I know you did a lot of work with that. I think it would be interesting to try to get the perspective here in Australia versus the perspective in the US. I know that the initial rollout of vaccines in Australia also wasn't the best, right? What were the big differences between the rollout of vaccination for COVID in the US versus Australia?
Well, actually, the rollout was very good in the long term. It took us longer than it should have to get the Pfizer RNA vaccine and then the Moderna RNA vaccine. We also had the AstraZeneca vaccine, which is a hybrid virus vaccine. The Moderna and Pfizer vaccines were RNA vaccines. And in fact, we had over 90% uptake in Australia of the 2 doses of those vaccines, particularly the RNA vaccines, but initially AstraZeneca as well. Extraordinarily, you usually find that it's difficult to persuade people of diverse languages in a country to actually take the vaccine. Out here in Western Sydney, where we have people of diverse languages and ethnic origin, they did wonderfully well, like 95% uptake of the vaccine itself. And so obviously deaths plummeted, the lockdowns and the need for lockdowns diminished, but then we got the waves, and trying to convince people to take boosters declined progressively over time. So only 36% had a 4th dose here in Australia, and the same in the USA. But the big difference was in the USA, there's a substantial proportion of people did not get the first vaccines. And this is very patchy across the country, and it does have a political dimension to it when you look at red versus blue states.
Yeah. I want to talk a little bit more about the politicalization of it.
Yeah.
First, about the vaccines themselves. You mentioned AstraZeneca. I saw in the news that they're like ending the vaccine now. Why is that happening?
It's not quite as effective as the RNA vaccines. It doesn't have the same flexibility. The amazing thing about the RNA vaccines is that within 9 months we had a vaccine. The herpes vaccines I referred to previously have taken 25 years for development. So one of the things RNA can do, and we're now looking at the possibility of platforms where you have the vaccine all set up, but you just flick out the middle bit of the vaccine and put another bit in. And that would give you, CEPI wants vaccines in under 100 days. So if another pandemic turns up, like the flu spreading in cattle in the USA, that you could actually get vaccines readily set up. And of course, we want to be able to synthesize them around the world. And you can use these modular setups to synthesize RNA vaccines. Moderna and BioNTech are producing them, and now we're starting to see vaccine setups in Melbourne to supply the region, 100 million doses a year, and we're seeing this in Cape Town to supply Africa. So this is a huge step forward, the RNA vaccines. And I think there's 2 reasons why AstraZeneca has decided to stop. One is it's very difficult to compete with the efficacy, the flexibility, and there was also this very rare side effect, but a very nasty side effect, which is thrombosis and low platelet counts that can actually lead to death in rare occurrences.
Only from the AstraZeneca?
Only from AstraZeneca and the Johnson&Johnson adenovirus vaccines. It's got something to do with adenovirus. Even natural adenovirus will rarely give you these types of side effects.
So the Johnson&Johnson vaccine, was that a similar vaccine to the AstraZeneca one?
That's right. It uses adenovirus as its... adenovirus is a common virus we actually find in the community, and people used it as a carrier for the COVID proteins because it's so innocuous. We can be infected with adenovirus and you might get a minor cold from it, or most of the time you get nothing. What we didn't anticipate is these very rare, severe side effects.
And was there a reason why Johnson&Johnson canceled their vaccines so earlier on and AstraZeneca only did it now?
You'd have to ask them. That would be a commercial decision, I would think.
But it wasn't just because of the side effects?
Well, I think there was, as you know, court cases, and you'd have to go and ask AstraZeneca and Johnson&Johnson how much that versus their sales influenced their cessation of production.
Yeah. Something else that you mentioned quite a few times here is the idea of vaccine hesitancy. So I feel like that would be cool to talk about too. mRNA vaccines. I think that just the idea of having an mRNA vaccine was one of the points of hesitancy for people. Can you explain what an mRNA vaccine really is, and did they exist before the COVID vaccine?
So I'll say one thing first. Before COVID, about 5% of people would absolutely refuse to take vaccines. And that is because people are not ill, they're well, and so basically they don't like having things put in their body. There are various reasons for this. Then there's hesitancy, about another 15%, where people are unsure whether to take the vaccine or not. And in fact, if you talk out the issues with them, they often will agree to take the vaccine. With COVID, we had an additional issue. Some people, of course, hate compulsion, and vaccine mandates were a natural red rag to a bull to some people. And the RNA vaccines, there was a lot of myths spread, particularly on the internet, how you could get computer chip into a tiny needle that would inject you. I have no idea, but that was one of the myths that went around. And another myth that went around is that RNA vaccines were just suddenly pulled out of the air, whereas in fact, if you look at the science, and I've actually got a little slide on this, it's a combination of a whole range of chemistry, nucleic acids, etc., had been developed over a period of 10 to 15 years. And in fact, some of these companies, Moderna and BioNTech, had RNA vaccines actually almost ready to go for other viruses when along came COVID, and they just accelerated their use and off they went. Now, some people have been concerned RNA vaccines, being nucleic acid, will get into the nucleus and into your DNA. That doesn't happen. The RNA vaccines get into the cytoplasm of the cell. They don't get into the nucleus. And in the cytoplasm of the cell, the RNA is converted into protein, and the protein is either exits the cell or sticks on the surface and induces all those good antibodies and effectors that we need.
Yeah. One thing that you also mentioned there was that these companies were able to actually produce the vaccine a lot quicker than many other vaccines, like the herpes one that you said has been developed for 20 to 25 years now.
Yeah.
How did they do it so quickly? And should people have been worried as they were that it was produced so quickly?
No, there's a difference between the evolution of the vaccines and the science over 10 to 11 years and the rapidity with which they could produce the vaccine. So I distinguish those two, I think, in terms of vaccine development. The reason for this is that RNA, and it's a fascinating story, RNA to many scientists, including myself, is a very fragile molecule. If it sits on your skin, the enzymes on your skin will destroy it. So we're very careful. And you may remember in the early days, there was a great deal of concern about how you preserve the vaccines in terms of how you freeze them, how long you keep them thawed after you bring them out of freezing. And there's a little fatty envelope that goes around the RNA, which protects it to some degree, but only to some degree. So it's still fairly fragile. So the reason that you can produce these RNA vaccines so quickly is that we can use enzymatic or chemical reactions to do it, rather than growing things up like the first shingles vaccine in big vats of virus and then inactivating them and then putting them in vials, etc., which can take months to years. So the rapidity of the RNA is extraordinary, and because it actually codes for individual proteins, you can produce RNAs very quickly off templates, and they're really ready to go. But I do distinguish between the development of RNA vaccines that took 10 to 15 years and the rapidity with which they could be produced in giant vats. And those giant vats, as I said, are flexible. So in the future, if we get another pandemic, we're not going to get this problem, I hope, of the rich countries hogging the vaccine and the poorer countries, eventually coming up behind, and not only hogging the vaccine, but hogging it for future second doses, third doses, rather than the first two.
Yeah. So you mentioned earlier that with the mRNA vaccine, you can just replace part of it, and then that's a whole new vaccine for whole different condition.
That's right.
Can that also be done pretty quickly, even quicker than we might have done with COVID?
Yes, that's what. And there are meetings just recently, and one of our Australian scientists has been involved in this, at producing a regulatory framework, because all of this is very carefully regulated, and the regulators talk to each other in Australia and the USA and Europe. And this is called a platform technology, and so you'll have to build rules and regulations around it, and stipulations, how it's done, make sure that the companies that are producing this, everything is kept identical except that little sequence in the middle.
Yeah, no, that's really interesting. Another thing, clinical trials. How long were the COVID vaccine clinical trials?
So from go to woe, including clinical trials and emergency use authorization, it was 9 months. In fact, both companies, the day after the sequence was released, and the sequence of COVID, of SARS-CoV-2, was released from China together with Eddie Holmes, who's here in Sydney, and he's working in collaboration with the Chinese professor who did the work. So there was a lot of concern about publishing this, of course, again, a political issue, but the day after it was published, the companies were out making the sequence and then constituting it quickly with that protective fatty envelope, lipid envelope, and then, in essence, organizing with expert clinical trialists to do the trials. And we had an emergency use authorization with 9 months. That's extraordinary. Imagine if we could have done this in 1918-19 when we had pandemic flu and 50 million people died.
Yeah. No, that's really cool. Another point of vaccine hesitancy, I think, was the idea of side effects, people thinking that they might get side effects from the vaccine. What were some common side effects cited that people said they got from the vaccine?
Well, I think people were concerned about some of these myths that I mentioned, and they were particularly concerned about genetic effects. They were concerned about the chips, as I mentioned, and I think also people were concerned that they might get autoimmune diseases, which do occur. There were very rare occurrences of inflammation of the heart in young males, which led to great care in prescribing this, particularly in young males. Fortunately, that was mild, and what people didn't realize is that COVID itself gives you an inflammation of the heart which kills, and the vaccine inflammation does not. You actually get the virus in the heart itself, just as you do in the brain and the lungs, and this can persist and cause long COVID, of course. So certainly there were concerns that that was more frequent than people were letting on. It's about 3 in a million that this happens, this rare, mild heart inflammation in young men. Yeah. So the focus was in older generations, because we know that if you're over 80, you've got a 20-fold chance of dying of COVID compared to someone in early adulthood, and then it goes down. Under 70, it's about 7 to 8-fold, and then between 60 and 70, it's about 3 to 4-fold. And the other vulnerable people are those who are immunosuppressed or have serious heart and lung disease. Yeah.
So given that you are one of those 100 million people, you said? 100 million? Yeah. Could you therefore have, say, mild long COVID symptoms even if you didn't get COVID, but you just had those symptoms from the vaccine?
No. The vaccine does not give you long COVID. Yeah. As I said, the major side effect that has come out of these RNA vaccines is incredibly rare, and your chances of, the vaccine will protect you against a much more common and much more severe side effect of inflammation of the heart, which is much more severe and can kill.
Mm-hmm. And then I think there were also some people that said that it could cause autism. I know that there was that
cause
autism. There was the 1998 study that got discredited.
Yeah.
But what was the impact of that early thought that it could
Yes, this was a guy named Andrew Wakefield, who was a GP in the UK, and he published a paper in The Lancet suggesting that the measles, mumps, rubella vaccine, which is widely given to kids, of course, it is a standard vaccine of infancy, and he claimed that there was an increased incidence of autism due to what was called MMR, measles, mumps, rubella. It turns out that some of the data was not true. In fact, it was considered to be fake, and the paper was withdrawn by The Lancet with apologies, and in essence, the British authorities struck him off, and he went to the USA after that, and there has been a continuing, lingering issue. And of course, if you stop people getting measles, mumps, rubella vaccine, up go the incidence of congenital rubella, up goes the incidence of measles, which is not a benign disease, and in essence, again, can cause all manner of problems and causing immunosuppression, causing heart and lung disease in kids. So really important. Mumps, not so bad. That just causes, inflammation of the testicles and the ovaries in older males and females.
And did this study have a significant impact in the number of people that weren't getting the vaccine?
Yes.
Yeah.
Yeah. It actually put people off getting the vaccine, and he publicized his findings.
That's interesting.
A lot of other people, anti-vaxxers, took it up.
Yeah. Right. I think another interesting point is the lack of trust in the government. How is that different, say, in the US and here in Australia?
Well, I think it's true in general that the World Health Organization and the American Medical Association and certainly vaccine psychologists will tell you that if you really want to trust a source, it's usually the general practitioner you go to. So it's very important that GPs are well educated about vaccines. And in fact, you'll usually find if they've got a good vaccine, they'll be very enthusiastic about it. If it's not such a good vaccine, they won't be so enthusiastic. So that's one of your most trusted sources. The trusted source in Australia was our Chief Health Officer, who is a doctor, very good doctor, standing up next to the Premier almost every day and talking about COVID and talking about the problems with COVID so that people were well educated, not panicked, and actually there was good access, there was good follow-up to vaccines. So we immunised, once we had the vaccine, we immunised very quickly and efficiently. So people don't trust politicians on a lot of issues, do they?
Yeah, no, they don't. No, they don't. But and how is that different in the U.S.?
In the US, as far as I could see, there wasn't the same sort of interaction between public health officials standing with politicians. You did have the redoubtable Professor Tony Fauci, who's superb, but you also had politicisation of this. In Australia, we had a bipartisan approach to immunisation and even to lockdowns, which are now a bit controversial in retrospect. Did they go on too long in terms of mental health issues, and all the other issues are about lockdowns and viability. So in the USA, there was very clearly a dichotomous approach between Democrat and Republican about immunisation, and this led to uptake, which was good on the coasts and not so good in the centre. But I can show you a map which indicates that it can vary county by county. Now, we also saw this same problem in internationally, and even in low and middle income countries. New Guinea, for instance, people were not keen on taking the vaccine, and we do know that around the world, people were less keen on taking subsequent boosters than the initial 2 doses. And of course, we had a problem in low and middle income countries with supply, and that was a major issue that I think will hopefully be solved in the future. So we had COVAX, which undertook to buy vaccines cheaply from suppliers and then get it to low and middle income countries. Didn't work quite as well as we would have liked.
Yeah. In terms of the booster, should people still be taking the booster? Like, what's the significance of COVID now?
One of the things that we found with COVID, of course, is with Omicron, it's more infectious and less deadly. Not only that, it's on top of a well-immunized population. And so what we're seeing is that people are still getting infected with waves, the latest Omicron variants, JN.1 here, and it's a bit different in the USA. You've got the next one, and they are usually quite infectious, the Omicron variants, but they're causing mild to moderate disease. I just had it myself a few weeks ago, got it in a vaccine conference, but we're not seeing severe disease, and the reason for that is that we think that there are two arms of immunity. One of them drops off over 6 to 12 months. We're charting that at present in our studies. We were just looking at that a moment ago. But the white cell immunity, the T cell immunity, stays up to a better degree. So the recommendations are, if you're over the age of 75 in Australia, get your booster at 6 months. Try and keep those antibody levels up. Still a nasty virus to get, and basically you don't want to go to work when you've got it. If you're between 60 and 75, then 6 to 12 monthly is recommended. You can take it at 6 months, but you should take it at 12 months. And really important, if you're immune compromised, you have severe heart or lung disease, then yes, you should get a 6-monthly booster as well. If you're Indigenous people, then that recommendation goes down to people over the age of 50.
Why is that?
Because they're much more susceptible to the spread of these viruses and these illnesses, and there is actually a greater immune susceptibility too of Indigenous people.
Okay. One interesting thing that Dr. Fauci and I talked about in combating vaccine hesitancy was the spread of misinformation. And he said that we shouldn't try to stop the spread of misinformation because that's nearly impossible, but we should push out the spread of good information and good education. What are your thoughts on that?
Yes, it's the vaccine psychologists that I work with make it very clear that authoritative information is really important. But if a particular piece of misinformation is being spread on the internet, you need to be aware of it and combat it very quickly, as it'll get away. So it's really important for that authoritative information to be transmitted quickly, which is one of the reasons why our Chief Health Officer and our Premier stood up every day in press conferences. It was an extraordinary performance, really. And that happened in Victoria too.
Yeah, because I think one of the big issues is there's just so much misinformation out there, right? That it's hard to go through all of those clips and say, oh, that's misinformation right there. But then one of the issues that Dr. Fauci and I also talked about was actually creating positive information.
Yeah.
He mentioned that a lot of the people that have the right information and are educated enough to talk about these topics, they don't really have the time to go on the social media platforms and create all these videos like the people that create misinformation can create, you know?
Yeah. One other thing that's really important is to have champions like Dr. Fauci, but you need people within the community. And I remember talking, I used to appear on TV a lot during the pandemic, and we have, as I said, different ethnic groups and linguistic groups here. And if you can get someone like one of our GPs in the West here, particularly in our Islamic population, who's in fact promoting vaccines, going on television, talking to community groups, that is enormously effective and more effective than putting it onto our broadcasting services that broadcast in multilinguistic fashion. Yeah.
Yeah. And in the U.S., I think that was pretty significant with the African-American population too, the vaccine hesitancy at the beginning because of, the history of how the medical community really treated African-Americans, which is understandable.
Tuskegee.
Exactly. Yeah. But being able to involve those community leaders, I remember hearing that a bunch of church leaders were involved. And when all of that involving the community started happening, that's when you saw the African-American community really taking up the COVID vaccine a lot more, which is super interesting.
It's also true that here in the West, we have a lot of intergenerational families like Italy, which had, and these are people who are living together from grandchildren through to grandparents. And so you get a lot of spread of the virus, and of course it's the grandparents who cop it. And so those communities actually saw this happen, and that actually amplified the message, and that is, this is something we've got to prevent, or we're going to lose our beloved grandparents.
Yeah. As I mentioned earlier, I was in the Outback last week, middle of Australia. How did you guys see rural areas respond to vaccine uptake?
Yeah, I think this is why I'm saying, places like Brewarrina in Outback, New South Wales, it was a little slower maybe than it should have been, but I think there's certainly been a huge emphasis on and a great interest in this country in Indigenous health. But again, it's really important to have community leaders who are willing to promote immunisation and make sure that hesitancy doesn't take hold and myths don't take hold. And they can take hold very clearly in any of these communities, including the Indigenous ones.
Yeah, no, I completely agree. We touched on this a couple of times, but long COVID. I feel like I see long COVID, hear about long COVID all the time, but I don't really understand what counts as long COVID and what it really is. So if you had to define long COVID, what would that be?
Well, it's actually symptoms of COVID that persist beyond 3 months. And about 22% of people will lose that at about 6 months are the estimates. The problem is, as you quite rightly implied, there are 180 symptoms of long COVID. And there's a mix of physical and also psychological impacts here that lead some people to, in essence, be suspicious of his existence, which is unfair. You do see 3 clusters of symptoms, 3 main clusters: lung, where people can actually get abnormal, we can actually test, and we have done in this hospital through one of my colleagues. You can actually show that a majority of people who've been admitted to hospital 6 weeks later have still got abnormalities of their lung function. And that can go on to scarring of the lung. Then there is the heart side effects, because the receptor for SARS-CoV-2 is found in the heart. And in essence, this can also lead to particularly to what's called postural hypotension, where people's blood pressure plummets when they stand up and they faint. That's been well documented. And then thirdly, there's the brain fog issues, I think, as well. And we're still learning. I reviewed, actually, for one of our granting agencies, a whole stack of very good grants going into this. We still don't understand how long COVID occurs. It almost certainly relates to cascades of abnormal immunity that are actually doing this, which actually we know, for instance, we mentioned herpes before. If herpes gets in the eye, some people can actually lose the virus, but they get ongoing inflammation in the eye, which can cause scarring. So viruses can do this. We know that Epstein-Barr virus was classically a cause of prolonged fatigue. Well, I know that the virus I studied, Ross River virus, which causes arthritis, can have prolonged fatigue and recurrent symptoms. So we're still learning exactly how this occurs, and it may occur in different ways in different people. So plenty of reason for medical research to continue and to continue to be funded, I might mention.
Yeah, no, I think it's really interesting. So in those three body parts, the lung, the heart, and the brain, do you still see remnants of COVID, say 6 months after the infection?
You still see effects. Of course, we can't biopsy the brain. We don't biopsy the brain. You can. We used to for herpes simplex and encephalitis. We don't anymore. And you don't biopsy the heart and the lung. You can actually at least do lung function tests. And so you do see the sequelae of this. Exactly what the cause of these sequelae is really not well enough understood. We know in mouse models you get inflammatory cells persisting, and these inflammatory cells can then lead to scarring of the lungs. So that's the presumption that this is a similar cause. And is it caused by persistence of the antigen in the viral protein in some area? Probably not. It's probably actually a precipitated immune reaction that's self-perpetuated.
And do we think that will go away at some point, or is long COVID kind of persistent?
It does in a proportion of people. We probably have not got really good studies going out to 12 months, 2 years, but certainly at 6 months we know a proportion of people lose it.
Yeah. So just as an example here, when you get COVID, you can get inflammation of some of the cells in the heart, and even though COVID might be gone a month after that, that inflammation stays there.
Persist. Yeah.
Okay.
Exactly.
Okay. Very cool.
Same with the brain. That's what we think is happening. As I mentioned, that's because we've used models, animal models of this. Yeah. Animal models not really good. The people have used chimps and things, macaques in the past, not chimps, but and the models are not really good because they don't get the same pattern of disease as humans do. Yeah. So we're still finding out.
So are there any areas of treatment for long COVID right now, or not really?
Yet. People used in trials a drug for diabetes called metformin, but that's only been done in one trial as far as I'm aware.
Mm-hmm, mm-hmm. In terms, I know one of my friends always mentions psychedelics. Has there been any good studies with long COVID and brain fog and psychedelics?
No, I haven't seen any.
Okay, interesting. I know a lot of, you mentioned like the politicalization of vaccines. In terms of lobbying especially in the US, right? Because I think a lot of lobbying is to keep vaccine and drug prices high to be able to recuperate those R&D costs from the beginning, right? Mm-hmm. And a lot of the points against that is that other countries are getting it for cheaper, but only us in the US have to pay such high prices. What are your thoughts on that?
Yeah, I think that we're now producing those vaccines in Australia and Cape Town, and that's good to see. We've got Moderna here and Sanofi here now, and Sequoia, of course. So I think that's actually probably not the case with vaccines anymore. Vaccines are being produced around the world. Certainly, there is an antagonism in the USA to the sort of systems that we have in Australia and Canada and also in Britain. But here we do have a private system, we've got a public system, and we have universal health insurance. And of course, that has been incredibly controversial in the States. You know more about this than me, Obamacare, etc. So I think it's the heterogeneity of healthcare in the USA which leads to the USA being perceived as not as good a healthcare system as countries like Australia and Canada. I mean, the OECD rates these, and I don't see that this is going to change very much. At least it's not me, it's my colleagues in the USA tell me it's not going to change because the system is embedded. But certainly there are some voices in the USA that are saying that we're subsidizing the rest of the world. I don't think that's really true. And I think actually the pharma companies would make that fairly clear for vaccines as well.
When pharma companies in other parts of the world besides the US, say here in Australia, they make a new vaccine, how do they recuperate all of the research and development costs?
Well, unfortunately, we haven't seen a lot of R&D costs, R&D from vaccine companies done in Australia, and this is something that we want to see, and that's why it's great to have Moderna and Sanofi here. And so you're right, the costs of hepatitis vaccines, for instance, pretty high, and they've been maintained for some time. The Australian government actually subsidises vaccines, so in essence, pharma companies sell their vaccines to the Australian government that actually distributes them. Mm-hmm. So that funding, of course, goes back to the vaccine companies to continue to do their research. Now, the vaccine companies that I collaborate with as researchers are based in the States and in Europe. So I'm actually helping those countries with their money and with mine to actually advance research in vaccines.
And do you see significantly different strategies among those U.S. pharmaceutical companies versus the European pharmaceutical?
No, not really, because I think they have to think globally. And when they're running their trials, and this is one of the problems, the trials are very expensive, and they're very expensive because of the experience we've had with adverse events from disasters, like some of the drugs causing congenital malformations, etc. So regulation is very tight. Emergency use authorization was not as tight because that was critical. So but most of the companies actually want to make sure that their vaccines are going to be sold around the world in every country. They want to sell a vaccine here, same price here as in the USA, and they want to sell it in Europe. And so what do? They run their trials in Europe, the USA, Australia, Japan, South Korea, etc., to ensure that regulatory authorities see that their populations have been exposed to these trials and in essence have the same response as others. So there are certain countries that are very keen to make sure when trials are published that a subset which relates to their country is analysed separately and they get the same answer.
Yeah, cool. I've been seeing a bunch of cool vaccine stuff in the news as well. One interesting one was like the vaccine for melanoma. Have you looked at that at all? Like, how does that work?
So melanoma is one of the most immunogenic cancers you can see. We did a lot of work in melanoma here, and of course it's a disease which has dreadful prognosis, dreadful future. Like within 3 years, I'm struggling to remember the figures, but more than 50% mortality. Both my uncle and my cousin died of malignant melanoma. And one of the extraordinary things that's happened recently, and the two people involved in this who became Australians of the Year, and that's Georgina Long and Richard Scolyer, were running the trials, and some of those trials actually started here using immune therapeutic drugs. So they're not actually vaccines, they're antibodies against two particular proteins called PD-1 and CTLA-4, if you want to know. And so those immunotherapies have completely changed the prognosis of malignant melanoma, the one that spreads. Melanoma can stay very stable and not spread. If it gets deep into the skin, then it'll spread, and it's disastrous, affecting the brain and everywhere else. So that's immunotherapy, and companies are now saying, well, seeing we can do so well in controlling this cancer immunologically, we can take the proteins from the cancer cells and treat people. And one of the things that is happening is this is personalized. Your tumor is yours. So we'll take some of your tumor cells and create a vaccine and treat you with that vaccine. And that is one of the interesting research enterprises at present, but it's not, it's in trials. It's not being used yet.
So when would you get this vaccine, and what does it do after?
So this would be immunotherapeutic vaccines that, again, are RNA vaccines that I know Moderna and BioNTech are producing, and they're putting these things into trials, and I don't know the time frame.
Yeah. Okay, interesting. But so you would take it after you get melanoma, and would that be even if you just have like an easy episode of melanoma that you just remove?
I think again, I'm not an oncologist, but what I'm almost certain would be the case is that the likely future, the prognosis of that particular melanoma would be assessed, and you might have immunotherapy as an augmentation to taking it out surgically, or alternatively, if you've already got spread melanoma, the immunotherapy may be used for that.
Oh, okay. That's really cool. Yeah, never did I think that vaccines would be used for cancer. Do you see this same type of treatment being used for other forms of cancer? I know I saw that Richard Scollier that you mentioned, he used it for his brain cancer.
Yes. And
it completely freed him of cancer.
Well, this is using those antibodies. It's not actually a true vaccine. It's antibodies against PD-1 and CTLA-4. Yes, certainly. And tumors, cancers differ in their immunogenicity. Some of them are not, and some of them are. And of course, we can wander off into CAR T cells, which are cells that are now charged with being able to treat cancers as well. But that's a completely different of immunotherapy.
Yeah.
And people are doing that in this institute. They're using it for myeloma and all sorts of other cancers. So some cancers are highly immunogenic and some are not, and pancreatic cancer, for instance, I think is not very immunogenic. But don't push me on that. I'm not an oncologist.
Yeah. So do you know what Richard Scollier did for the...
Well, his colleague, Georgina Long, I think, supervised his treatment and used antibodies that are used against melanoma. And in essence, he's, for the moment, free of what is a very nasty, rapid-growing tumor called glioblastoma in the brain. Yeah.
That's really cool. What do you think the implications of this would be, say, 10 years in the future?
Well, let's just hope that he remains disease-free. It's a bit early to tell.
Yeah. I think one last interesting topic is AI and vaccines. Where is that right now? I saw that there's the AlphaFold 3 that came out by Google this week or last week. How does that really work? I've just been seeing it everywhere. I read a bit on it, but I didn't really understand.
You're one up on me. One of the things that we're seeing with bioinformatics and AI is the capacity to predict structures. So in research, we can now not only look at the sequence of proteins, we can look at their shape. And if we understand their shape, then we can actually look to see how antibodies or drugs might actually attack them. And I presume that's what you mean by AlphaFold, but I haven't read what you've read.
Yeah. So you can see the protein that's created by a virus and then give that to, say, AI,
Yeah.
And AI can try to create models that would fit into that protein?
That's right, yeah. Now, we've been doing that manually for years. We have here in the university people who are protein modelers, and in fact, we've worked with them ourselves in trying to produce antivirals. So they'll actually tell you what sort of, and if you've got a candidate protein, they can know, a candidate drug, should I say, they can say, oh, yes, it'll fit here or fit here. And we're doing that at present with antivirals against herpes. We're trying to see where they might actually attack a particular external protein of herpes. And we know that this particular molecule is antiviral. We don't know where it binds, and we can either predict it with that type of modeling, or you can go and do special type of electron microscopy to see where it binds.
So say you have this one viral protein, are there a ton of different models that could actually fit around that? And is the hardest part really figuring out which one of those would work?
So when viruses get into cells, it's the spike on the surface that actually binds to the receptor. And one way to get around that is to try and block that spike from binding to a receptor. And so being able to predict where that might occur depends upon you understanding the shape of the protein that's the spike, the shape of the protein that's on the cell, which means you have to have been able to purify them and develop and actually characterize them by either electron microscopy, what's called cryo-electron microscopy, or crystallography, which is more sophisticated. Yeah.
Mm-hmm. Usually, do we spend a lot of time in this modeling phase? Like, do you think it will save us a lot of time in the whole drug process?
Yeah, one of the problems with the at a manual level, at least, people use computer predictions all the time, but AI is a new thing on top of computer predictions. Is can we get a finite library of folds? Again, this is not my area of specialty, but I've read about it, whether you can get a finite library of folds. So you actually look at the whole of the human body and all of the proteins, and these are, if you know the sequence, this is the type of fold of physical structure that you'll get. And that's really the holy grail.
Yeah, that's interesting. Complex stuff, though.
Yeah.
Complex stuff.
Very.
Yeah.
Beyond my capacity.
Yeah. No, I'm excited to see where this goes in the future.
Yeah.
With that, I think that was everything that I had. Do you have anything else to add?
You've given me a good going over, haven't you?
Yeah.
Here's just a little bit of, these are just things that I drew up and took from various places that you might be interested.
Yeah. No, that's great. I'll definitely take a look at it. Thank you so much.
It's a pleasure.
I learned a lot. Thanks. Thank you for tuning in to this episode of the Gustavo Franco podcast. We hope our exploration of the world of healthcare has been insightful and thought-provoking for you. The opinions expressed here are ours and of our guests, and should not be considered professional advice. This podcast is a collaborative learning experience for both the producers and listeners. While we strive to convey accurate and up-to-date information, we acknowledge that our research may have limitations. We encourage all of our listeners to supplement their knowledge by conducting their own research. If you enjoyed this episode and want to stay up to date on our future releases, make sure to subscribe or follow us on your preferred podcast platform and social media. We highly value your feedback, so please don't hesitate to reach out with your thoughts, questions, or suggestions for future topics. Together, we can foster a more educated America and contribute to a more effective healthcare future. Thank you for joining us on this healthcare exploration.